It's been kind of an ongoing issue in a lot of different areas of medicine is that women simply aren't represented in these trials. They're not included in these trials to the same extent that men are.
Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 134 of the Strokecast. Today's episode is brought to you by Modus Nova. To find out if Modus Nova can help you recover a limb after stroke, visit strokecast.com/Modus Nova. And by Like Minded. To learn if this membership program is right for you, please visit strokecast.com/Like Minded. Research and studies are, of course, critically important to understanding stroke survival and figuring out what we can do. I mean, they determine what treatments can save lives and which ones are just going to be too risky. They separate legitimate medical treatments from snake oil, scams, and charlatans. And they do a great job of that. For men. Is the research just as effective for women? Probably. Maybe. Well, we can't be sure. And that's a problem. Michigan State University students Brent and Julia Pudar just published a study this spring showing that women are significantly underrepresented in stroke research by anywhere from 6 to 20 percentage points. And that's a problem since it means we may not be able to generalize results from studies across the sexes. They published the study in the prestigious JAMA Neurology journal. It's even more impressive that they published it while Julia is still in medical school and Brent was still an undergrad. Today, Brent Strong joins me to talk about their process, their research, their results, and just how this disparity happens and why it matters. So now, let's meet Brent. Brent, thanks so much for joining us here on the Strokecast this week, right as you're running into graduation from university. This is awesome.
Yeah, it's my pleasure to be here. Thanks for having me on.
The reason I wanted to talk to you is that you and your partner, Julia Pudar, recently published a study in a JAMA article, Journal of the American Medical Association, showing that women are underrepresented in stroke studies. So what does that mean?
It's been kind of an ongoing issue in a lot of different areas of medicine is that women simply aren't represented in these trials. They're not included in these trials to the same extent that men are. And in this case, we sort of defined underrepresentation with reference to the wider stroke population. So we used some data from a study called the Global Burden of Disease to look at, for example, in the United States, what percentage of strokes are occurring in women. And we compared that percentage to the percentage of trial participants, people who were enrolled in these clinical trials who are women. So that was how we kind of defined underrepresentation. Like women were underrepresented if they made up a lower proportion of trial participants than they do for the reference stroke population, like in the United States or in China, because we had studies from all over the world. It just depended. But that was our definition, how we really looked at it or approached it.
So when you start looking at those numbers, what percentage of folks who experience stroke are women?
It's pretty close to 50%. So we found our middle estimate was about 50.8% of the stroke population was women. In the United States, it's more like 53.5%, I think is what the American Heart Association estimates. And we know that, for example, subarachnoid hemorrhages, one type of stroke, women are more likely to have those. So it really depends, although it's generally pretty close to 50%, at least based on the data that we were looking at.
And as you look at the overall data that you're seeing from your studies, roughly what percentage of study participants then are women?
Yeah, so overall, I think it was 43.4% were women. So that right there is kind of concerning because, as we said, the middle estimate was about 50.8% were women. And then on average, women were about 43.4% of the trial population. So you can already see there that there's a pretty large gap. And that was even more severe in certain studies, getting to be as large as, 20 percentage points.
6 percentage points doesn't sound like a whole lot when you're talking about a group of, say, 100 people. But I suppose when you start talking about groups of hundreds or thousands or tens of thousands, that can start to add up pretty quick.
Yeah, no, absolutely. So, I mean, in our study, I think there were over 100,000 participants we looked at that were enrolled in these trials. So those seemingly small percentage differences on a population level, they translate to very large numbers of women that are being under-enrolled. And of course, we know that these sorts of trials that's what are being used to actually inform how strokes are treated. So they have this very large population-wide impact. So the fact that women aren't being represented in these trials as well as men, well, that's very concerning because these trials affect what kind of stroke care stroke victims receive all across the world.
We're starting to see broader discussion about how stroke symptoms manifest differently in women, where some of the be fast messaging, which absolutely folks should be using as a starting point, but we're starting to see more symptoms manifest differently in women, and women tend to face some of the higher risks too, due to things like estrogen-based birth control medications and of course other things related to that.
Yeah, no, absolutely. I think the symptom thing that's a really important one because, those typical stroke symptoms that everyone recognizes, they often aren't there in women, and that affects how they're treated. And in fact, it could probably affect whether they're enrolled in the trial, because when you're bringing someone in with a stroke, they obviously have to be actually having a stroke to be enrolled in these sorts of trials. So it may affect people's ability to recognize that those women are eligible, and it definitely affects how they're treated with, drugs like IV alteplase and things like that.
The IV alteplase, something that most of us are more likely to know as TPA, as the clot buster medication.
Exactly.
And of course, even when women are diagnosed as stroke, I imagine a lot of these studies are also focusing on that golden hour of treatments, what makes sense in those first few hours. And if you delay diagnosis, and we see that where anecdotally and in some studies, other studies that have come out, we're starting to see that women are less likely to be believed when they go to the ER complaining of symptoms, or less likely to have their pain taken seriously, and the problem gets magnified even more with women of color.
Yeah, no, absolutely. And I think that's a really big issue because, as you talk about, that golden hour is really essential for, treatment with both TPA and then also mechanical thrombectomy or endovascular therapy. It's very time dependent, the benefit. And there's all sorts of things that suggest, women may be disadvantaged in that respect. For example, women are more likely to live alone when they're older, so they might be less likely to have their symptoms recognized in time to receive those treatments. So that's definitely an ongoing issue. We actually did look at it a little bit in our study published in JAMA Neurology. We didn't really find an association, although that obviously doesn't exclude the fact that it's present and may negatively impact enrollment into these trials if women arrive later than men.
I think one of the things too that a lot of us don't necessarily think about until we start looking at this stuff in a lot more detail is that this whole question of studies and analyses really affects a lot based on the population that you're looking at. I mean, I think it's one of those things we've started to become more aware of, even when we look at some of the sciences that are less microscope driven, like psychology and sociology, and some of your colleagues in the communications fields, is that so many of those studies looking at how people actually behave and respond, and some of the most famous psychology studies are all based on primarily college age men. And now we're seeing more college-age women in those studies, but not the broader population, just because they happen to do those studies on undergraduates, and that's the population available.
That's probably the key reason why we study this whole issue, is that these clinical trials, they need to represent the populations that they're designed to serve. So if you're excluding women, then that's going to reduce your ability to generalize your results to the wider stroke population. And I mean, there are all kinds of other issues. People of color are less likely to be enrolled. Older people are less likely to be enrolled. And then generally, people in clinical trials tend to be better off socioeconomically, more engaged with their health. So really translating these inferences from the clinical trials or from other studies like in psychology or sociology to wider populations, that's really one of the key challenges, I think. And it's, I think a lot of really smart people think about this, but it's a very, very difficult issue to address. And I think one of the key ways it needs to be addressed is, as we talked about, ensuring that more women are represented in these sorts of trials or studies in psychology or sociology, whatever the discipline may be.
So now we've got some of these questions about, the differences in diagnosis rates and things like that impacting it. But what else is impacting this gender gap in the studies? I mean, why does this happen beyond just the questions of when somebody arrives at the ER and gets identified as as somebody who's experiencing a stroke?
I think there are a variety of things that really impact it. In our paper, we looked at eligibility criteria. So a clinical trial typically limits who can be enrolled in the study. For example, they might prevent someone with kidney disease from being in for a variety of reasons. And there's a couple things that we looked at. Probably the most important is age caps. So funnily enough, a lot of clinical trials actually limit participants to those who are 80 years or younger, or maybe 85 years or younger. And I think this is done for a variety of reasons. Perhaps that these people who are older are less likely to have a good outcome. So why try the treatment in them, that kind of thing. They may not be able to tolerate the treatment. We know that TPA has a lot of side effects. But the problem is that women have a lot more strokes at older age than men. So there was this one analysis of some German data that found that if you put an upper age cap of about 80 years on a trial, you're going to exclude 44% of possibly eligible women, but only 19% of possibly eligible men. And we kind of backed that up with our analysis that showed that putting this age cap on enrollment is really to women's detriment in terms of enrollment. And of course, it's also to older people's detriment. You're less likely to enroll an older population that's going to be more representative of the stroke population. And there's a variety of other things that probably contribute as well. As I said, we really looked at eligibility criteria, but there may be things like women are less willing to participate. There's some data to suggest that they're more risk averse. They're more worried about the possible risks of being involved in a clinical trial, and they want to avoid enrollment for that reason. There could be larger biases in trial design. For example, if you have a trial that enrolls participants from a Veteran Health Administration's facility, you're going to enroll a lot less women because most veterans are men. So there's really a whole constellation of things that contribute to it. We really hammered down on the age criterion because I think that's a really big contributor and one that could be fairly easily addressed. Well, I think there needs to be a lot more research to really understand what's going on because it's a big issue, not just in stroke, but in cardiovascular disease and cancer. It's received a lot of attention from people.
There's certainly some logic in doing some age caps when you start factoring in comorbidities or other things that people are experiencing because, we're human beings and people don't just have a stroke. They may also then have been living with other chronic illnesses or other disabilities or have other things going on, which can make parsing data a lot more complex. And the older somebody gets, that becomes more challenging. But of course, when you start to see these impacts of some of these exclusions that exist for, what seems to be good reason, but once you start teasing it apart, you start to see all these other problems that come from that.
Yeah, exactly. And, no one's really acting in bad faith. I think if you don't think a treatment's going to work in a certain population, you don't want to give it to them because, treatments have risks. I think what we really suggested and what one of my professors I work with, Matt Reeves, has suggested in a recent editorial he published was that investigators need to be better at imposing eligibility criteria that really reflect what they're worried about. So, for example, if they're imposing an upper age limit of 80 because they're worried that people who are older than 80 will be very frail and not be able to undertake treatment, well, a better method to address that would be to use some sort of frailty index and use that to exclude people rather than age, because there are probably plenty of people who are older than 80 who can tolerate treatment just fine. And there may be people who are under 80 who can tolerate treatment just fine. Same thing with comorbidities. There could be older people who don't have them or younger people who do. So I think more directly addressing the issues that may complicate treatment or make the risk-benefit ratio for treatment not worth it is what really needs to be done rather than just imposing these age caps as a proxy.
Yeah, and age becomes a simple but sloppy proxy for other conditions.
Yeah, exactly. Very sloppy, I would say.
So as you looked at this data worldwide, did you see or observe any differences in these populations based on countries where women's rights are more of an issue, or where equal rights is more of a challenge? Are you seeing those border societal variances country by country as far as gender enrollment in studies happens?
So we actually didn't see a whole lot of regional differences, surprisingly. We only looked at it in very large regions. So we only had a couple categories. One was the Americas, which was virtually all North American studies. Another one was Europe, and then one was Asia, and then the final one was multi-region studies. We did see that Asian studies enrolled women a little less than men. And this was after accounting for the fact that in countries like China, it seems actually the proportion of strokes occurring in women is a little lower than in like North America. So actually, I think most ischemic strokes occur in men in China, whereas most ischemic strokes occur in women in the United States. So there was a slight difference. Asian countries seem to have some difficulty. Of course, it's hard to really understand why that may be the case. It could definitely be women's rights. I mean, I think one hypothesis for why women are less likely to be in these clinical trials is that they may have a higher family burden or something like that. They're not able to participate because they have competing demands, and, as a woman with homemaking or work or things like that. So that could factor in. But we really didn't see huge regional differences, somewhat surprisingly.
And nothing like two guys getting on the recording here to talk about women's issues.
Yeah, exactly.
So I joke, but it's important to keep that in mind as well. I think the China data there is, I think, interesting too, because one of the things, I guess it's about 2 years ago now, we saw the big study that came out reflecting overall stroke risk worldwide, which showed that that was where we see the figure that comes out that says 25% of adults over the age of 25 will experience a stroke in their lifetime. And I think what the data showed in that study for the United States, I think the number was actually about 24.8% or 24.9%. But China actually had a higher percentage than most other countries in the world as far as likelihood of experiencing a stroke in your lifetime, and seeing gender differences in there. I think that, I don't know what to make of those data points, but I think that's an interesting area to look at, some of the whys and what's happening there.
Yeah, stroke is terribly burdensome in China, so I completely agree. I think it's definitely something that has to be looked into. I think perhaps it has to do with certain lifestyle characteristics that may differ between developed countries and more developing countries, like maybe a higher prevalence of smoking. But that was very interesting to see that.
But the main reason you're seeing this happen is the likelihood is the age caps then. So when we start looking into the data, and I don't know if your analysis was able to go into this level, but do you see this gender gap persist when you look at younger stroke survivors, those under 40 or under 50 or under 60? Or
Yeah, that's a good question. So we really didn't dive too deeply into that issue. We did actually try to look at what's the mean age among women in the trial versus what's the mean age among men in the trial. We just couldn't really find the data. So there wasn't a whole lot of data regarding age reported by gender, so that really limited us. And then, of course, a lot of these trials, although they're maybe capping some enrollment at like 80 years in some cases, they're still fairly old populations, in the 60s or 70s, most of the patients are. So, yeah, we really didn't get the chance to delve too deeply into that data, although I'd be very interested to see whether that association changes or not for younger stroke survivors.
Yeah, absolutely. Definitely an area to for future study, with 1/3 of all folks experiencing stroke being under the age of 65. It's something we talk a lot about in this community because, our demographic skews younger a bit.
Yeah, for sure. It's pretty scary too. I mean, thinking about what a high proportion occur among such young individuals. I mean, because that's much more difficult, I think, for someone who's young and has to spend a lifetime dealing with the disabilities or the issues associated with stroke. So, yeah, I think it's pretty concerning just and I believe it's rising, if I'm not mistaken, the proportion of strokes occurring in young individuals.
Yeah, we have been seeing those numbers increasing over the years. And that's another area that a lot of folks are looking at and understanding. I think we're seeing, there's some lifestyle shifts around that, but those are going all over the place because we definitely see, we see changes in everything from physical activity going down, but we also see smoking rates among younger people declining, but then vaping comes along. So there's a whole lot of stuff going on there.
Yeah, absolutely.
As a result of these studies, and of course these studies are often around, treatment protocols. That's the reason why we do these studies, to ask, does this therapy work? Is this therapy safe? Is it effective? Have you seen any examples of treatment protocols that show different results based on gender that may or may not have been reflected in the studies due to the gender gap in the studies?
One that does come to mind that has a little stronger evidence for it is there's actually some evidence suggesting that women benefit more from IV TPA than men do. And that's pretty important because there is some evidence to indicate that women are less likely to receive IV TPA. And they also consistently have worse outcomes in relation to stroke than men. So the fact that they are more probably or maybe more likely to benefit from TPA, yet receive it at lower rates and have higher disability is pretty concerning. But there are a couple of examples. And there's some well-founded biological rationale behind looking at sex differences, because it does seem that there are some biological differences between men and women in terms of how they respond to stroke. So I think that's a really big issue. These studies are designed to assess how beneficial the treatment is among both men and women, and they just simply don't enroll enough participants to really know whether the treatment actually differs between men and women. Now, if there are huge differences, you can probably tell that. But most of these studies just don't have enough participants to see small but meaningful differences. So that definitely needs to be an area of study, because while we have some data to suggest it in the context of IV TPA and nitroglycerin, we don't really know for a lot of other studies. Like, they very well could be to those sex differences, but we just haven't had the ability to accurately assess whether they exist or not.
And I think when we start talking about just the scale that's involved with there, I imagine this is probably out of scope of your study, but one of the things that's becoming certainly a much broader question that we're seeing talked about in the broader society at large is the question of sex versus gender. And with the broader visibility of the trans and non-binary identifying community. Was your study able to look at, or offer any insight into the different stroke experience that members of those communities or those who have undergone gender reassignment medical treatments may be facing, or is that study population that population represented in studies or identified in studies just a little too small?
Yeah, so we weren't really able to look at it. I think there's a couple of reasons. One is transgender individuals, I think, make up a very small proportion of incident strokes, so it's difficult to study. And then most of these trials reported biological sex. I'm not sure what that was in every study, but one of the clinical trials that I've worked on while I've been at Michigan State just used sex at birth, for example. So often sex is just reported as a simple binary, usually sex at birth, I would guess. So we just really looked at, what are disparities in enrollment based on sex at birth. But I will say that that's definitely an area that needs to be studied more, because there is some evidence to suggest that people who are transgender, who are transitioning from being men to women, who take certain hormone replacement therapy or whatnot, they're probably more at risk of certain vascular events, including ischemic stroke. So definitely needs to be studied more. And of course, those sorts of therapies or their unique socioeconomic circumstances might definitely impact how they respond to treatment. But unfortunately, I just don't think there are enough people to reliably assess that, although I'm sure it's important.
We're just coming up with a list of potential topics that other folks can start exploring as they start looking at developing their own research and publication strategy.
Yeah, absolutely. One of the professors we collaborated with at the University of Alabama, her name is Virginia Howard, she said, "Well, I know you published this study, Brent. I'm sure you're excited, but honestly, this kind of topic will keep you busy for the next 30 years, which I agree with. The more you think about it and the more you delve into it, the more you realize just how little we know for a lot of these topics."
So, I mean, as you said, there's definitely a lot more study there, a lot more resources there. We're really only starting to look at this, but I mean, what can or should the community of survivors sort of do with this information at this point?
Yeah, I'm So we mainly looked at acute stroke trials. So these were trials of treatment that occurred within 1 month of onset. So, for a lot of stroke survivors who've already had their stroke, they may not be enrolled in these sorts of trials, although having a first stroke makes you more at risk of having a second stroke. But I think a lot of stroke survivors like yourself are pretty heavily involved in research and, new ways that treatment can be done and things like that. So I think being aware of the issue that women are under-enrolled compared to men and advocating for investigators to enroll women and to look at treatment effects in women, I think is a really key way that stroke survivors who are actively engaged in trying to push those research efforts forward can be involved.
We don't necessarily want to put all the burden on the women in our community to go ahead and actively try to participate in more of these studies. But for anybody who and any men who are approached or considering participating in the study, I think it's reasonable to, when you're asking about the study before participating, asking about, what the study organizers are doing to drive gender equity or sex equity within their study populations.
Yeah, no, absolutely. I mean, that's a really, really important question, I think, to ask. So, because as I said, it's really important. If men and women were the exact same in every respect, then it really wouldn't be that as important.
And life would be a lot duller.
Exactly. But men and women do differ physiologically. And so it's really, really, really important to have them in those trials. So I think pushing that and wanting to see what trial investigators are doing to ensure gender equity and the representation of people who are historically underrepresented in areas of medicine, I think would be a really important thing to do, key way to help.
So I mean, obviously, we can, just keep talking about how important this is and all of that. But I mean, what inspired you to conduct this meta-analysis anyway, and to look into this in greater detail? And let me step back and first ask, what is a meta-analysis?
Oh, yeah, that's a great question. So a meta-analysis it's basically an analysis of studies. So studies conduct individual analyses, and then in a meta-analysis, you're typically analyzing a bunch of different studies and you're using statistical methods to pool the results. So in this case, we basically calculated a disparity measure for each trial, and then we used a statistical method to calculate an average, basically, that helps minimize bias. So it's a little more complicated than that, but it does a variety of things to help minimize bias and provide accurate inferences.
I was going to say, so one way to look at that is, an individual study asks the question of, does TPA benefit these people and looks at maybe results of 500 people there. Another study is, does using endovascular treatment to treat aneurysms benefit the stroke population here, benefit these 150 people? Does this pill work for recovery for these 200 people in a blind study? And then they get their individual results. But what a meta-analysis does is it looks at all of the results from each of those studies and then asks a question about those studies.
Yes, exactly. So, for example, the endovascular therapy, which we mentioned, in 2015, you had 5 different clinical trials that came out that showed that it's very beneficial for patients who have these very large strokes. And so they basically just put all the data from the 5 trials together, and then they analyzed it all together. And that's good because it allows you to estimate more precisely how beneficial the treatment is and to see if there's any differences between the different trials and how beneficial the treatment is. And in this case, we weren't meta-analyzing data related to treatments. We were meta-analyzing data related to sex disparities. So that's basically what we did in this study.
So why did you decide to look at that?
So I've been working with the professor, Matt Reeves, during my entire time at Michigan State. It was actually funny. I came in very interested in epidemiology. He's an epidemiology professor. And he studies chronic diseases. I was really interested in infectious diseases, but there's not a whole lot of people at MSU who are involved in the epidemiology of infectious diseases. So I just kind of randomly decided to work with Matt. And I've been working in stroke during my entire time and have just really enjoyed the work and, learning from stroke patients and seeing how devastating stroke can be and doing some small things to hopefully help improve that situation. And he actually was the one that kind of had the suggestion for me. He's like, this is a really big area in medicine, a really big problem in medicine, I should say, is that women are underrepresented. And nobody's looked at it in very great detail in the context of stroke. So I think this is a good study that you and I could work on together and I thought it was very interesting. I'd done some work previously looking at the undertreatment of women with IV TPA with Matt. And so we just started doing the study together.
How did you connect with your co-author, Julia Pudar?
Matt also teaches a class in the medical school on like an introduction to epidemiology. And Julia was a part of that class, did really well. I think she got the top score in the class, like 100% on the final exam. And then she emailed Matt asking him about research opportunities. And he said, well, actually, we've got this study going, and we were having some difficulty really getting it off the ground because we had to get all kinds of data from these different trials. And one of the key things you do in a meta-analysis to kind of reduce the possibility of errors is when you pull data from the studies, you do it in duplicate. So you have two different people do it, and then you just compare to see if there's any errors and you fix any problems. So I needed somebody who had the time and the motivation, because I was really excited about this study. Like I said, I think it's a super important topic and one I'm very interested in. But we didn't really have anybody else who could do it because Matt was busy with a variety of other projects. So we recruited Julia in to help with it. And
Because when you're looking for somebody with available time, first thing I think is a student at medical school.
Yeah, no, that's a great point. So she is obviously very busy, but Julia is super smart. So she was definitely able to find the time and still be successful in classes. But yeah, I agree. She managed her time very well to help out with it. I guess it's easier as well when you have like a medical student who's very hungry for research experience and like wants to be part of something versus, maybe recruiting another faculty member who is juggling all sorts of projects and things like that.
Then Julia was definitely involved in double checking the data and pulling the data from those studies as you were to make sure everything is aligned properly and you're working with the right numbers. But beyond that, how did you divide up? How did the two of you divide up the responsibilities between yourselves?
The collecting that data is probably the lion's share of the work for a study like this. And in this case, most meta-analyses will have very few studies, maybe 10 or 20. In this case, we had 115 we needed to go through, and we were pulling all kinds of data from them. So that was just a period of a number of months where she and I looked at the data separately and then had to compare for these 115 studies. And then she helped a lot with writing the manuscript, like revising it. And I did the statistical analysis and drafted the manuscript initially. But those data abstractions, pulling that data from those studies for the meta-analysis was a huge amount of work that we devoted most of our time to.
And definitely, it certainly seems like that time has been well rewarded. I mean, obviously, aside from just getting this data and starting or refocusing this important conversation, and beyond that, you've now had a study published in a Journal of the American Medical Association publication as an undergrad. I mean, what's that like?
Yeah, well, I feel really grateful for the opportunity just because, Matt's had me in his research lab for this entire time. And then I've just been able to work with great people like Julia and a couple other people that we collaborated with in Australia and elsewhere in the US. So just it's hugely gratifying. And then it's also very exciting because while the quality of the journal or how well known the journal is definitely doesn't determine how good the research is, this is a really important issue. And, having the chance to get your work published in a JAMA journal, JAMA Neurology specifically, it ensures, I think, a wide audience, which is good because if you really care about an issue, you want as many people to hear about it and be able to change their studies accordingly. So the fact that we were able to put this work in and then get it published in a high-profile journal where a lot of people are going to be able to see it, that's very gratifying. And it excites me because, as I said, it's an important issue and it's one that really needs to be addressed.
So, you're also basically sort of at the start of your career now. Like I said, there's potentially 30 more years of going through this stuff. But how has this project then sort of really impacted your education and career goals? Just personally, now that you've done this, where do you want to go from here? How has this maybe changed your direction?
It's been extremely beneficial for me in the short term. I think helping with this study, I actually was fortunate enough to win a Marshall Scholarship a few months ago, and I'll be studying at the University of Glasgow in Scotland for a couple of years. And
fantastic. They actually just had a really interesting study come out about vagus nerve stimulation driving, I believe, is upper limb recovery in chronic stroke.
Yeah, no, there's some amazing research groups there. That's one of the reasons why I could have chosen any university in the UK, but Scotland, particularly the University of Glasgow, has some great stroke research groups and look at all sorts of things just like that. And so that's been very exciting. I think longer term, though, it's really helped motivate me to want to be involved in stroke research for the rest of my career. I really want to do something similar to what my mentor has done, Matt, and be involved in that sort of stroke research. And then also, it's really engendered a passion in me for clinical trial design and for gender equity issues. So I think it's really important to design these clinical trials so that they are generalizable and that they can be used to make valid inferences about how larger stroke populations need to be treated. And then I think that one of the key things that undermines that in stroke and in other areas of medicine is the underrepresentation of women or inadequate awareness of peculiarities or things that are peculiar to women in regards to stroke and stroke treatment. So, yeah, I really look forward to hopefully studying a lot of these same things during most of my career. And it's definitely had a pretty large impact on me in that way.
So, Brent, if folks want to know more about you and what you're up to and, your work, where should they go?
I'm always open to emails. Email strongb5@msu.edu.
So, I mean, Brent, this has been great.
Thanks for allowing me the opportunity to be here. It's been a fantastic conversation. I really, really appreciate it.
And that brings us to our hack of the week. But first, let's talk about our sponsor, Modus Nova. Getting in your reps, your repetitions, is key to neuroplasticity and to recovering use of a limb after stroke. The Modus hand and Modus foot help you do just that while you play video games and get a score and get your results tracked. Powered by air and artificial intelligence, the Modus device helps you move your hand or foot if you have little control over them, and they apply gentle resistance to help you get more out of a workout as you get more control back. To learn if Modus Nova can help you, visit strokecast.com/Modus Nova. Use promo code STROKECAST for 10% off your first month. And now back to our hack of the week. In previous episodes, Kristen Aguirre, who recently got a job as a weekend news anchor in North Carolina, congratulations, Kristen, and Ruth Carroll both recommended using pumps for your shampoo bottles. It makes it easier to get to the shampoo in the shower when you only have one fully functioning hand. And those are great solutions. But what if your bottles don't support aftermarket pumps or come with pumps of their own? Well, you've got a couple of options. One is to just get empty pump bottles. I mean, they're readily available, and then you can just grab a funnel and pour your shampoo, conditioner, soap, lotion, or other assorted bath products into those bottles and just use those. I mean, this may even have the advantage of allowing you to buy larger, unwieldy bulk shampoo bottles and save some money since you're just pouring it into the smaller bottles or asking someone else to pour for you. One thing to be aware of with aftermarket pumps is make sure that they can handle the thicker or more viscous fluids that make up some shampoos. You may need a thicker straw on the pump than you might for something like, say, Windex or another very flowy liquid. Another option, though, is, well, it's one of the first things my OT Olivia taught me. If your arm is flaccid and you're in a shower chair, then what you can do is just put your affected arm in your lap and pour shampoo or your other substances right onto that forearm, and then scoop it up from there and onto your head or wherever with your unaffected limb. If you're not using a shower chair and therefore don't have a lap, then, well, if your recovery is far enough along that you're able to stand up in the shower, then you may also be able to bend your affected arm to be partially horizontal. Or maybe the tone and spasticity will bend it for you. Regardless, if you can get that affected limb to have the forearm be horizontal or almost horizontal, well, then you can still do the same thing. Just apply the substances to your affected arm and then scoop it off of there to apply elsewhere on your body. Now, this accomplishes a few things. For one, well, you can actually see how much of this stuff you're using. I think most ableds even use way more shampoo than they need, since they can't actually see how much they use when they apply it directly to their head, or when they just pour a whole bunch into from one hand into another. Secondly, and more importantly, it actually engages your affected limb. You see, even if you can't use the hand directly yet, it's important to keep re-engaging that affected limb whenever you can. You gotta make those limbs work, even if it's in a different way than before. I mean, engaging that side of the body continues to give data to the brain. It continues to teach the brain, and it reminds the brain that, hey, that limb is still there. It's important. It matters. We're not getting rid of it at this point. Is that all it takes to reconnect? No, of course not. But you see, every little bit helps. And everything you can do to engage an affected limb contributes to any eventual recovery and stresses those nerves in a good way. It encourages them to grow. And it gives you more bath cleaning liquid options. And now, I'd like to welcome a new sponsor to the show, the Like-Minded program from Heal the Brain with Jane. Like-Minded is a living, breathing recovery program. When you join Like-Minded, you get access to live virtual workshops to help all aspects of recovery. You can attend sessions run by stroke and TBI survivors, occupational therapists, physical therapists, speech therapists, and more. Many of the session leaders have actually been guests on this show in the past, like comedian Mimi Hayes, podcaster Joe Borges, and even Jane herself. You also get access to replays of those sessions and a private text messaging group for all your questions. Members also get free membership to NeuroFit VR, a virtual reality interface tool that helps you with your cognitive skills after brain injury. Get the support, accountability, and direction you crave and deserve for just $45 a month. Use promo code STROKECAST for 20% off your first month. And now, some final thoughts on today's episode. In thinking about today's interview, I'm of course well aware of the irony of two guys getting together to talk about the issue of underrepresentation of women in stroke research pools. Aside from that, it is an important discussion to have, and I hope folks designing their own research studies do take steps to include more women. We have a lot of good science. We need a lot of even better science. I also find this meta-analysis interesting for other questions that it raises. I mean, stroke touches on so many different demographics in a way that folks outside our immediate community don't even think about. I mean, Brent and Julia showed that one reason for the gender disparity is because studies look at older folks, but set the age caps at 80 or 85 for participants. And it leads me to wonder, does this same disparity in sex apply to studies that look at under 30 or under 50-year-old folks having strokes, or even folks under 65 years old having strokes? Well, we don't know, because there's not enough research targeting younger stroke survivors and folks who are younger and don't survive a stroke. What about in chronic stroke? Folks past the 30-day mark. I mean, the stuff that Brent and Julia looked at was all about acute. It was all about what's happening in those very early days of stroke. So when we start looking at treatments and studies around chronic survivors, do studies show a gender disparity or a sex disparity further along in the process? Again, we just don't know, because there hasn't been enough research done there yet. And are there similar disparities in research based on race and ethnicity? Again, we don't know. We can guess based on some of the things we learned from Ramlee Crowe a few weeks back that there probably is, but again, the research hasn't been done to look at that. And so there's a lot more work to do to really understand it. But I think what's really important is that we start having these conversations, we start asking these questions so we can get better results and save more lives with treatments that are going to be most appropriate for the right person. Brent and Julia's work It really highlights only one key problem, and it gives us a chance to ask even more questions. Science moves forward by asking and by trying to answer those questions. And with each published paper or study or research project or meta-analysis, we move a little closer to understanding the universe. But generating enough research with large, diverse pools and understanding how and if we can extrapolate to the larger community of humans is how we have to start. So that's it for this week. Be sure to visit strokecast.com/Brent for links to the study or to contact Brent with insights you may want to share. The Strokecast newsletter is scheduled to launch in July, so be sure to subscribe for free at strokecast.com/news. Share this episode with the research fan in your life by giving them the link strokecast.com/Brent. And of course, as always, don't get best. Get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you soon.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.